My name's Manali Kamdar. I'm an associate professor at the University of Colorado Cancer Center. At the European Hematology Association meeting today, I've had the opportunity on behalf of all my co-investigators to present data with regards to a few new things that are happening in the world of lymphomas. So as you all know, lymphoma is not one disease, but it's actually made up of nearly 108 different subtypes. And within these subtypes, we certainly have a lot to do in order to get everybody cured. But I will say that within aggressive lymphomas, we are presenting data in two aggressive lymphomas this year. One is in a lymphoma called diffuse large B-cell lymphoma, and in the second, mantle cell lymphoma. So why don't we first start with diffuse large B-cell lymphoma. So diffuse large B-cell lymphoma is actually one of the most common aggressive lymphomas. When initially patients present, roughly about 50 to 60% of patients can be cured with upfront chemoimmunotherapy, which leaves the remainder of patients which either initially respond to relapse later or don't respond at all. Previously, the outcomes for these patients were quite dismal because majority of patients either were frail enough to not pursue the standard of care, which was auto transplant, or patients who were transplant eligible received it but had a very minimal impact on their overall outcomes. Most of patients with diffuse large B-cell lymphoma that relapse, they relapse within the first year of having received their initial treatment. And in those patients, previously the outcomes with an auto transplant yielded only about 15% of patients to enjoy long-term remissions. Thus, there was a need to develop new treatments in this subset of patients. And with that came the advent of a new novel immunotherapy called CD19 chimeric antigen receptor T-cell therapy, also called CAR T-cell therapy. What is it? It basically is when we take patients' own cells, we take them to a lab, we isolate their fighter cells and we make them super fighter cells. And then we reinfuse those cells back into the patient and let them do the job that they had forgotten to do. So basically, with CD19 CAR T-cell therapy, there have been multiple new advances, but the advance that I'm going to talk to you guys about today is with regards to a CAR T-cell therapy called Liso-cel, also called Liso-cel. So with that, there was a study that was designed, now nearly 3.5 years have passed, where patients have been in follow-up for the study, but this was called the TRANSFORM study, and it was truly transformational. The TRANSFORM study was a phase 3 study where patients were randomized who had relapsed with diffuse large B-cell lymphoma within 1 year of having received their treatments to either getting standard of care, which was then considered an auto transplant, or Liso-cel, which is CAR T-cell therapy. Initially, just at the 6-month follow-up mark, there was a benefit that was seen with Liso-cel versus standard of care. A follow-up was later presented at the 17-month mark, which showed that Liso-cel or Liso-cel showed superiority over autologous bone marrow transplant, and thus the FDA as well as the European associations have approved Liso-cel in patients with relapsed refractory diffuse large B-cell lymphoma in the second-line setting. It has replaced the previous standard, which was considered to be an auto transplant. Not only is it efficacious, meaning patients actually maintain their remissions longer, but it was also much more safe. In terms of safety or in terms of toxicity, they did not have toxicities that were seen with an auto transplant, like low blood counts that translated into multiple infections for a long time. Patients of course had low blood counts, but these were low blood counts that could have reversed or resolved over a period of time. CAR T-cell therapy causes unique toxicities. One, primarily because the T cells that we reinfuse into the patients, they basically activate and cause tumor death. And when that happens, it sets off a cascade of diffuse inflammation that is called cytokine release syndrome. And sometimes that can also cause neurological symptoms. So with all the previous constructs with CAR T-cell therapy that we have, the cytokine release syndrome or the neurotoxicity is quite notable. But what is assuring in this study is that with Liso-cel, the cytokine release syndrome or the neurological toxicity were not high grade, which means they were completely resolved with interventions. They were primarily low grade, and patients could manage these toxicities with their caregivers very well. Part of this infusion was also given in the outpatient setting, thus basically establishing that Liso-cel is considered to be now the new standard of care in patients with relapsed refractory large B-cell lymphoma. What I am presenting at the European Hematology Conference this year is a 3-year follow-up of this same study. And the reason we continue to present follow-ups is to understand if the promising efficacy also has durability, meaning if patients have done well, do they continue to do well? And the long and short of it is that yes, TRANSFORM study continues to show superior efficacy with regards to Liso-cel over auto-transplant. Patients continue to have remissions that are much more durable, much longer. They have shown no new side effects. There have been no new toxicities that have been seen at now the 3-year mark. So with that, I think Liso-cel does have a curative potential. Initially, when we used to see patients with diffuse large B-cell lymphoma, we used to say your first shot is your best shot because that's your shot at a cure. But now with Liso-cel and this study at the 3-year follow-up, we can now say that Liso-cel has potentially also a curative potential in the second-line setting, thus providing a breath of fresh air for patients who have relapsed with diffuse large B-cell lymphoma.